Welcome to the session on treatment for chemical dependency. We're going to take a look at treatment and intervention as it pertains to individuals with chemical dependency and chemical addiction problems. There are several components to treatment, and just to give you a brief example, some of these include psychotherapy and counseling, Alcoholics Anonymous, or self-help groups, and that also includes other type of self-help groups such as Narcotics Anonymous, Overeaters Anonymous, Gamblers Anonymous. All of those are considered to be self-help groups. There's also aversion therapy and then psychotropic medication. And what we want to do is take a brief look at these examples of components of treatment. Now, first let's look at psychotherapy and counseling. Examples of psychotherapy and counseling include individual and group therapy. And the thing to remember when we look at individual and group therapy is that individual psychotherapy is seldom used in isolation or by itself when we're working with individuals with chemical dependency problems. It's usually used in conjunction with the other areas of self-help groups such as Alcoholics Anonymous. It's used also with medication or with pharmacologic therapy. It's used with vocational rehabilitation. And you can also kind of think of this type of intervention as a progression. And as we move forward in assisting the individual with the chemical dependency, we keep adding these components as we go along. And also remember that counseling by all means can include and should include some type of confrontational focus. And often we think of confrontation as something negative or having some kind of negative connotation, but confrontation within the context of treatment of individuals with substance abuse is not negative. What confrontation really entails is taking the information that you receive from the client or from the patient and presenting that back to them in order to confirm or even to challenge inconsistencies in the information that they're providing. So don't think of confrontation as some type of negative, hostile, in-your-face kind of approach when we're working with individuals with substance abuse. The thing also to remember when we use confrontation is that you also have to look at the individual you're working with. You have to look at that person's self-esteem. You have to look at where in the process, in the treatment process, that person may be. And confrontation has been proven to be more effective with some groups and not as effective with other groups. For example, confrontation has not been proven to be overly effective with women. It has not been proven to be overly effective with ethnic and racial minority groups. And that's primarily because you're dealing with individuals who have always had to deal with some kind of confrontation and some type of negative forces as it relates to their identity. So always consider the person you're working with, the situation, and that person's self-esteem and where they may be in the process, if confrontation is indeed a part of what you want to use. But keep in mind that confrontation here does not refer to any type of hostile confrontation. It is really a technique that is using to challenge individuals in terms of the information they have presented. Now, another example of individual and group therapy is brief counseling or brief therapy. And brief therapy is used in particular situations and with particular individuals. Brief therapy or brief counseling is not intended for those individuals whose problems are serious to the point that they actually have a label of alcoholism. But it's intended for those with less serious problems. It may be for those individuals who, if you want to use the term, identified as problem drinkers. And these are the individuals who may, whenever they consume alcohol, they have some type of situation, some negative situation they end up in. And it's not the addiction in the sense that the person has a chronic, but whenever they do drink, they end up with some kind of problem. That's brief therapy or brief counseling is pretty effective with those individuals. But for those individuals who have a chronic problem, brief therapy or brief counseling is not advisable. And brief counseling consists of the individual having 1 or 2 sessions of assessment and advice at the most. A lot of time individuals who go through brief therapy are those individuals with a problem behavior, but for whatever reason they cannot go into an inpatient treatment, or they cannot get into long-term counseling. And a lot of times that may be work-related, that may be financial, it may be family situation, but 1 or 2 sessions typically of assessment and advice is what an individual will get in brief counseling. Often this type of therapy or this type of counseling is developed for delivery by professionals who have some kind of specialty in working with individuals with substance abuse or some type of alcohol problem. And those other professionals, other than rehab counselors, for example, that may provide brief therapy could be social workers, it could be physicians, it could be probation officers, or it can even be employee counselors. One of the main modes of brief intervention is the use of self-help manuals and other forms of bibliotherapy. And bibliotherapy simply refers to reading materials that may be assigned to an individual. Brief therapy is most often aimed at the goal of moderate drinking rather than total abstinence. And one reason you may find difficulty in getting approval to use brief therapy is because we go by the medical model, which means that the individual must abstain from a substance, and the goal is not moderate drinking or teaching someone how to control their drinking. The goal is for them to stop, to totally abstain from drinking with the medical model. Whereas with brief counseling, we're saying, here what we're doing is we're saying we want to help the individual control their drinking, to look at moderation rather than total abstinence. So again, that is why the target population is those identified as problem drinkers, not those identified as alcoholic or those with some type of chronic diagnosis. These are individuals who have low or moderate levels of alcohol-related problems or alcohol dependence. The promising mode of delivery as a part of the health education and general health promotion is good for brief therapy. A lot of times, because what people are getting, they're getting a lot of information, they're getting strategies on ways to change their behaviors. And so this is a way that the public can receive education rather than treatment. So it's providing information about ways to change behaviors. A second component of treatment is that of family and marital therapy. Now, the characteristics of clients most likely to accept and complete marital and family therapy. These are some basic characteristics of individuals who are quite successful using this approach. Typically, the individual has a high school education or better. The individual has full-time employment, and if they're not working full-time, they have a very high desire to work. This is also an individual or who would be successful with family therapy are those who live together, and if they are separated, they are willing to reconcile for the duration of the therapy. And keep in mind, that's so important, because what we're talking about here is intervention with the unit, not just the intervention with the individual. Family and marital therapy, these individuals will be successful if they have had serious problems of longer durations, because by then we're seeing a very set pattern, and with this set pattern, there are ways to identify specific objectives and goals, and usually that longer pattern or that longer duration means that it has had some type of impact, some serious long-term adverse impact on the family and on the marital unit. Also, individuals who are more likely to accept family and marital therapy, they're older. These individuals enter therapy after a crisis, especially one that threatens the stability of the marriage. Oftentimes when individuals are faced with, okay, you either get some help or this marriage is over, those individuals with that characteristic are more amenable to coming in and receiving some type of family and marital treatment. And also the spouse and other family members who are not substance abusers or alcoholics, if that is the case, those individuals are much more amenable to this type of intervention, and they tend to have a fairly high success rate with family and marital therapy. So when we really think about what are the goals of family and marital therapy, well, first and foremost, it is to reduce the abusive drinking, or hopefully eliminate the abusive drinking, and support the alcoholics or the substance abusers' efforts to change. That is one of the primary goals. And again, this is why the family component of this is so crucial, because we are not just changing the abuser or the individual, we are also changing those around that individual. Because if we only change the individual and we fail to change those other individuals will continue to work on the old model of the old behaviors that we have seen in the substance abuser, and that person has now changed, but the family members have not changed. So what we have are people who will be functioning in two different types of behavioral systems. So you want to reduce or eliminate that abusive drinking, and also get the support of those family members to help in that process. The second goal is to alter the general marital patterns to provide an atmosphere that is more conducive to sobriety. Oftentimes what happens within the marital unit is that the non-substance abusing spouse has made so many accommodations in order to keep the family functioning that that person's behavior in many ways can also become dysfunctional around the patterns of the abuser. And what happens here is when the abuser's behavior change, and that other person now who's had to do so much and had to have had so much control is still working in that same mode. So it's going to be so crucial for that whole atmosphere to change in order for that person to be successful in their recovery process. Social skills is the third component when we look at intervention and treatment. And when we talk about social skills, what we're really talking about here is having some focus on ways of improving coping skills. And this is so important in the initial phase of treatment in order to reduce the risk of relapse. And relapse, of course, is fairly high within the first 3 years of someone being in recovery. So what you really want to do is work with an individual on how do you change these behaviors, how do you change your social skills and your interactions in order to not only successfully stop but to maintain sobriety and to not relapse. A good example when we think about why social skills are so important in the recovery process is that these individuals who've been abusing substances, their social network typically consists of other people who also abuse substances, or of other people who accommodate them in ways that their substance abuse can continue. So what we really have to do is think about ways to help this person cope once they're out of that kind of socialization and to keep them from relapsing. The desired outcome is to improve coping strategies. So what we're really talking about here is seeing a shift from maladaptive strategies to active behavioral or cognitive coping methods for that individual. And what will need to happen is that the individual will have to come up with strategies and be prepared to react to those social situations that might occur, because keep in mind, just because the individual is the one who has to maintain sobriety, he or she may continue to be around other people who will not maintain sobriety, and that may not be the other individual's goals. So what's going to happen is that that individual will have to have some type of coping strategies, behaviorally and cognitively, and how to respond when he or she is in this kind of situation. Often we talk about the individual removing him or herself from certain situations in order to reduce temptation and in order to prevent relapse. But we know that is not always possible in social settings. So we have to have that individual equipped with certain types of strategies and skills in order to respond behaviorally in the appropriate manner. So one example could be that that individual will have to recognize, if I go to the certain situation and I know that people will be drinking in that situation, I need to know what those antecedents are. And those antecedents are basically, one, what do I do before I get there? Once I'm there, B, the behavior, how will I respond? And based on B, how I respond, I will have to look at C, the consequences. And those consequences will be dictated by what I do behaviorally. So that's why it's crucial for some kind of coping strategies. They really, and this is an ongoing process. One set of coping strategies may work in one situation, but it may not work in another situation. So the person really has to be equipped with more than just one type of coping strategy in order to be effective and in order to reduce that risk of relapse. Okay, we also identified Alcoholics Anonymous as one of the components of treatment. And AA, or Alcoholics Anonymous, views alcoholism as a physical problem. It views it as a mental problem. It views it as a spiritual disease, and as the only viable alternative is lifelong abstinence. Okay. Now, keep in mind, when we talk about spiritual disease here, we're not talking about religion when we talk about AA. Spiritual is more of an emotional, more of a feeling. It's an internal thing. So it's not a religious thing. And there are two basic types of AA meetings that an individual can attend. There are your open AA meetings, and then there are your closed AA meetings. And for open AA meetings, anyone can go who have an interest in Alcoholics Anonymous, and you don't necessarily have to have a drinking problem just because you go to an open AA meeting. Whereas a closed AA meeting is only Alcoholics Anonymous members, okay, or people who would like to do something about their drinking. Okay? And also, when we talk about open and closed AA meetings, it may be open and closed based on the type of membership that is in that meeting. For example, a closed AA meeting, we tend to find people who may be in some professional position and they do not want to be recognized by others. For example, physicians who are in recovery may go to closed AA meetings, and that membership may consist only of other physicians or medical personnel. You may have people within the business community who cannot afford to interact in an open meeting because it may compromise their business or it may compromise their ability to earn a living. So there are certain group type of memberships that may also be closed. Open AA meetings, as I said, you can go as a member or you can go as an interested party. You can find open AA meetings typically sponsored are located at least in public areas, in churches, in community centers. But those closed AA meetings tend to be off the beaten path. Their listing, their meeting dates, their times are not advertised. It's also a very important part of the Alcoholics Anonymous experience is partnership and sponsorship. And what sponsorship simply means is that there is an individual who is also in recovery and a part of AA through membership, and this person who agrees to be a sponsor for a new person or an incoming person, this sponsor is further along, has made much more progress in the recovery process, and is able to assist that new person coming into AA to achieve and maintain sobriety. And another important part of AA is the 12 steps and the 12 traditions. And the 12 steps and the 12 traditions refers to the chronic physical and emotional isolation of the active alcoholic, and how this can be alleviated by sharing one's worst with another person. So the 12 steps kind of help the person get through a process. And these are affirming steps as a person moves through the recovery process. Another component of treatment is aversion therapy. Now, aversion therapy is designed to reduce or eliminate the desire for alcohol by producing a negative response to alcohol. Aversion therapy, again, is used somewhat still, not overly used today as it once has been used in the past. And the most common types of aversion therapy include electric shock, nausea, apnea, and imagery. Now, electric shock is just what it sounds like. It is painful shocks that a person will receive with the consumption of alcohol. And the shock is usually administered to the hand or to the arm as the client reaches for or tastes the beverage. Clearly, this is not one that we see used at all because of ethical issues related to it. And it's not been proven to be overly successful even in the past when it was used. Nausea is another common type of aversion therapy that is used, and this is simply the introduction of nausea is usually done by chemical means. So it's by medication, that a person will take this medication, and if they consume alcohol, the resulting outcome or feeling is that of nausea. Apnea produces paralysis of breathing for about 60 seconds. And during this paralysis, an alcohol beverage is placed on the lips of the patient, and that person will have a very highly aversive response as a result of that association of the alcohol and of the restricted breathing. Clearly, this is no longer used because, one, it's too severe, the high risk of death, suffocation, and it is such a severe nature that, if there are real ethical implications and violations that typically occur with this kind of treatment. Imagery is usually some kind of court sensitization, and what it involves is the pairing of imagined unpleasant imageries with imageries of drinking. So it's really a person is presented, for example, with some kind of a picture, and whatever's in that picture is something negative, and that negativity is what is connected with drinking. It has minimal risk. It's easily done. It can be done on an outpatient basis, and this is something that can also be used by paraprofessionals. So it's just getting the person to say, now imagine when you're doing this, vision that. So this is not anything aversive about it, but what you really want to think about is that the first three we mentioned are very aversive, highly controversial, serious risk problems involved, and serious ethical issues involved as well. So, and another type of treatment that can be used is that of psychotropic medication. And there's some basic reasons why psychotropic medication can be used with alcoholism, and these reasons they have a long history in the treatment of alcoholism. And the first reason is that there is a need for medications to relieve symptoms of withdrawal during alcohol detoxification. And keep in mind that someone who has been drinking, who is a chronic alcoholic, and in order to go into treatment and be receptive to any kind of treatment, the alcohol must leave the body. It must get out of the body. The way that happens is that the person must go through some type of detoxification process. There are risks involved with detox. There are physical, life-threatening risks that can occur with detox. So that's why certain type of psychotropic medications may be used to relieve those very severe symptoms of withdrawal that the person will go through as they go through the detox process. And keep in mind, the detox process at a minimum is about 72 hours. Another reason for the use of psychotropic medication in the treatment of alcoholism is that there is a close association between alcoholism and psychiatric problems for which drugs are a useful form of treatment. A lot of hallucinations may take place when a person is a chronic alcoholic and has been using and drinking and may be on a binge. So those psychiatric problems are usually worsened or exacerbated by the use of the alcohol. And that coexisting psychiatric disorder, or it may even be an alcohol-induced psychiatric disorder that gets worse with the use of alcohol, and the psychiatric problem must be addressed in order for a person to be receptive to any type of treatment. So this is another example when psychotropic medication may be used. And a third reason for the use of psychotropic medication is the drugs may have the potential to reduce alcohol consumption or to at least alter its effects. And this may be true even in the absence of any type of other psychopathology being present. Some types of medications that will be used in the treatment of alcoholism. You have benzodiazepine, lithium, antidepressants, tranquilizers, and antipsychotics. Now, let's define what we mean by these. Benzodiazepine is used basically in the treatment of alcohol withdrawal symptoms. So when a person is going through the detox process, that's when more than likely they're going to be administered some benzodiazepine. Lithium is helpful in reducing drinking in individuals who also have depression. It's inappropriate to prescribe lithium routinely to alcoholics with no diagnosis of a primary affective disorder. It is potentially dangerous because the therapeutic dose for manic depressive disorder closely approaches the levels of toxicity. So if you have someone who is already had experiencing some toxicity from the alcoholism, and then they received this relatively high dosage of lithium. I mean, that is a lethal cocktail. So that's very problematic to use lithium simply to treat the alcoholism. Antidepressants are used because depression is one of the most common psychiatric problems that coexist with alcoholism, and it can be imprudent to affect treatment. While there is no indication that antidepressants should be routinely prescribed for uncomplicated alcoholism, concurrent major depressive disorders may be treated accordingly after a 2 to 4 week detection period, provided that there are no medical or psychosocial contraindications. Tranquilizers, as a rule, is used, of course, as sedatives, hypnotics, anti-anxiety agents. That's when we typically use tranquilizers. And underline, highlight, put in quotation marks that tranquilizers are to be avoided in the treatment of alcoholics in the rehabilitation phase because of their potential of producing dependence, this kind of synergism with alcoholic or with the use of alcohol, and then there's a danger of overdose. So as a person is in rehab, tranquilizers, again, are not to be used. The risk is too high that they will then either become dependent upon those tranquilizers, or there's also the danger of overdose. Now, antipsychotics are contraindicated in the rehabilitation of primary uncomplicated alcoholism. They have a relatively high risk of side effects, including some type of dyskinesia that might happen. And when we see antipsychotics used, they're typically used during detox, and they are not used during the treatment phase. So again, keep in mind that when we talk about the types of medications used, these medications are certainly used in inpatient. They are highly monitored. The individual variation, the condition of the patient, the other coexisting disabilities, especially when we're looking at psychiatric disorders, must be taken into consideration when we talk about the use of medication as a part of the treatment protocol. Now, a few things to bear in mind when we think about treatment, or the principles of treatment. Keep in mind that there is no single treatment that is appropriate for all individuals. There is not a one-size-fits-all. Treatment needs to be readily available. And when we say treatment needs to be readily available, for individuals who need to get into a treatment program, for those substance abusers who need to get in quickly, we cannot look at placing those individuals on a waiting list. The difficulty with that, of course, is that it is difficult to find treatment programs that do not have a waiting list, especially those that are public ones where the person does not have private insurance in order to pay for that treatment. In the ideal world, the person should be able to get into a treatment program when they need it. And sometimes what happens for individuals who must get in right away, they're not covered by insurance, they can't go to private. A lot of times those individuals get in on an emergency admit base, or they at least get into a detox program because they can at least start that process for those first 72 hours. Another principle of treatment is that effective treatment attends to the multiple needs of the person, not just the substance abuse. Keep in mind that the substance abuse is usually a manifestation sometimes of other issues. It is not just substance abuse in isolation. people tend to have problems because with substance abuse sometimes because they also have other problems. Okay? So we cannot think that if we just treat the substance abuse that, okay, everything is okay now and we've taken care of that problem. It is critical. This is a critical principle in treatment that needs to be implemented in every case, that the person not only needs to be treated for the substance abuse, they need to receive the psychosocial adjustment, they need to receive the counseling. There are family issues that have to be addressed. There may also be financial issues. So what we're basically saying is you really have to look at all areas of the person's life when we talk about treatment. It's not just the substance abuse itself. Another principle is that the care plan needs to be reviewed periodically and adjusted to meet the person's changing need. Why is this so important? Well, events happen in a person's life, and counseling interventions may need to change accordingly with those changes that occur in that person's life. So periodic and systematic review of a patient's treatment or the client's treatment will facilitate targeted interventions to maximize treatment outcome. Another principle of treatment is that remaining in treatment for a sufficient length of time is critical for effective treatment outcome. Now, when we kind of look at the literature, when we look at research studies, these studies repeatedly show that the longer the patient or the client remains in treatment, the more benefit they receive, and the more likely they are to remain abstinent at the follow-up. Little improvement is probable for at least 3 months. So the longer the person stays in the treatment, that means in other words, they're getting the full benefit of treatment, and they tend to do better. The relapse risk is lower. Not saying that it will not occur, but it is lower. And the person is typically coming out of a treatment program with more skills, more of those coping skills on how to respond in a situation. Another important principle of treatment is counseling is a critical component of treatment. Now this applies especially to pharmacologically oriented treatment modalities such as methadone maintenance. Clients or patients are unduly focused on getting the medication and consider counseling as secondary importance. While the medication can control the narcotic hunger, it does not necessarily rehabilitate. It is necessary for that client or that patient to receive counseling to make lifestyle changes. So again, it's not just the substance problem that's being treated. It is learning coping skills and making lifestyle changes. Okay, let's continue with the principles of treatment. Next principle states that medications are an important element, especially when combined with counseling. Okay. Again, keeping in mind we're talking about the appropriate medications here. Some counselors believe that if a patient or a client takes prescription drugs for addiction, then they are not truly off of the drugs or off of the substance. This is absolutely incorrect. Many patients need the psychiatric medication and can improve by using it, especially when engaged in a therapeutic counseling relationship. Our next principle, substance abusing clients with mental disorders need both disorders treated in an integrated manner. Well, this is true. It's been a source of concern that a treatment dilemma for those on the mental health side who believe that a patient's psychiatric condition could not be treated effectively as long as the substance abuse problem was not adequately treated. And conversely, on the substance abuse side, they believe that the treatment abuser with a mental health disorder could not be treated unless the psychiatric condition was adequately treated. So, what happens when we have these duly diagnosed patients? Well, counselors kind of realize that the best method is concurrent treatment of both disorders. However, and this has been an effective way, but keep in mind that when we still have to consider the type of psychiatric disorders. Clearly, if somebody is in a psychotic state, they're not going to be receptive to treatment. It's going to be very important to get the psychosis under control in order to have any movement in treatment. So, concurrent, if it's possible, that is the best way to do it. But if we're talking about someone in such a condition and such a psychotic state, that condition must be addressed first. Okay. Our next principle states that detoxification is only the first step and does little to change long-term drug use. What we've seen in studies is that approximately 95% report failure rates after detoxification, if detox is the only intervention. Detox must be followed with a strong aftercare plan that includes counseling and relapse prevention. Keep in mind, again, when we say what is detox? Well, detox is simply the removal of the substance from the body. And detox within itself will not help an individual get better without some kind of counseling and some kind of treatment. Okay. Detox, keep in mind, is not a treatment. It is a step in the process of treatment. And to simply remove the substance from the person's body, that's all you're doing with detox. And then the treatment begins. Okay. Our next principle, involuntary treatment can be effective. Well, while many believe that a client or a patient has to want help in order to get help, and that if that person has some sanction at work, some sanction by the community, or that person somehow ends up getting involved in the criminal justice system, that person may not do well in treatment because they're now being forced into treatment, and that it won't be effective. Not necessarily true. Involuntary treatment can be effective because often when the person is presented with the consequences of their behaviors and those consequences limit some of their alternative, they then have to face the fact that, okay, I've got to get something, I got to get in treatment, I got to do something, I got to get better. So we've always heard, I can't help you more than you want to be helped, or you're not going to get better until you want to get better. So, but sometimes involuntary treatment can be just as effective because you must put the person in a position to be more receptive to getting better. And that's what involuntary treatment, that's what sometimes when we hear about those individuals who are court-ordered, and after a person who's been court-ordered go through the process of treatment, they are grateful because they realize, well, if it wasn't for that order, I probably never would have done this. So involuntary treatment can be effective. It can be just as effective as voluntary treatment. Our next principle states that drug use during treatment must be monitored continuously. Well, patients can and will test the system to see if they can get away with drug use without being detected. Others will test the resolve of the counselor by continuing to abuse the substance. And yet others have not made that final decision to stop. They're there, they made it through the door, they made it to the initial meeting, but they have not yet decided, yeah, I'm committed to this and I want to stop. So only by providing procedures for detecting alcohol and drug use while in treatment will counselors know the true status of the patient. Keep in mind that just like incarceration, there's no foolproof process saying that a person will not get access to a substance while they're in a treatment program. So what we have to be aware of is that this constant and ongoing monitoring is one way to make sure that we are dealing with someone who is fairly clean of substance while in treatment. So, in other words, drug abuse can occur during treatment. That's why we have to make sure it's monitored. Individuals can find ways to get substances into a program while they're in treatment. Okay, our last two principles of treatment is that treatment programs should also do harm reduction. And by this we mean assessment and intervention of HIV, AIDS, hepatitis B and C, and other infectious diseases, and in particular sexually transmitted diseases. These diseases can affect a patient's response to drug treatment intervention. So what we're saying is that it's not just the substance that needs to be addressed in these treatment programs. We have to think about other potential harm that that person may be exposed to. You know, they may come in with other undiagnosed medical issues going on. So some type of assessment has to be done. And when we're talking about assessment for other types of conditions, one cue of a type of assessment that may have to be done is the type of drug the person's on. We know, for example, if the person is an IV drug user, more likely you're going to test that person for HIV and AIDS. Now, if this person had a history of participating in prostitution in order to obtain their drugs, clearly this person is going to have to be tested for some type of STDs. So knowing something about that person's history, not just what they're using, but some of the behaviors around that use will prompt treatment programs or councils to request that other testing be done. And our last principle listed here for treatment is recovery from substance abuse is often a lifelong process. Okay. And you will often hear that an alcoholic or substance abuser is not cured. They are, quote, in recovery, end quote. And what this simply means is that every day is a challenge, because at any given time that person can relapse. So the recovery does not end when they exit a treatment. The recovery is for the rest of their lives. And what we do know is that multiple episodes of treatment may be necessary before abstinence is established. You know? So a person can go through a treatment program, be very successful while in treatment. They can exit a treatment program, have a period of abstinence and success, but they may relapse. And that person may have to do some other kind of treatment protocol. That person may have to go back for some kind of refresher and then continue along the road of recovery. Okay, so recovery is a lifelong process. Relapse is a part of recovery. And when an individual relapses, that relapse should not be considered a failure, but it can be an indicator. It can give clues to both the substance abuser and to the interventionist of what needs to be done, what needs to be worked into a protocol, what other considerations need to be worked in a part of that person's care and a part of that person's recovery. So a relapse, if it's taken in the vein that it should be taken as a learning experience, the identification of issues that probably were not identified before, or, okay, now we really need to work on ways to help you shore up your response and your coping strategies. So, yes, relapse will occur. No, recovery is not a destination and a point in time. Recovery is a lifelong process. Now, something that's very important to consider when we're talking about interventions with individuals with substance abuse problems, and it doesn't matter what kind of substance abuse problem that individual has. What we're really looking at is, how do we help that individual to get better? And the way we help that individual to get better is we have to formulate a treatment plan. Okay? And there are some basic steps, some basic components into the formulation of a treatment plan. And what you see listed here are the components that are required in treatment plans. And most treatment plans require these components. So let's take a look at what these are. And keep in mind that you will see some variation depending on who the person, where the person, inpatient, outpatient, etc. But there is a growing consensus in the literature that suggests that patients require formal treatment plans that contain certain, quote, common, end quote, features. Okay. Now, the most plans require the recording of patients' information to include identification of the problem or problems, what will be both the long-term and short-term goals, what is identified as the behavioral outcome, and basically the behavior outcome criteria, which determines whether these goals have been accomplished, stated in objectives and measurable terms. It's not just saying, well, you need to change this and you need to change that. What we mean by behavioral outcome criteria is that there is a means to get to the goals, the long-term goals, short-term goals. Objectives will be stated of how to get you to those goals, and those objectives must be stated in measurable terms. Also, there must be listed as a part of the treatment plan methods of intervention. What is it that's going to be done to assist this person to get better? And keep in mind, typically intervention includes multiple methods. There also should be something about the frequency of treatment. How often will this person participate? That can be the person coming in for group counseling, doing individual counseling. Whatever it is, there needs to be some concrete count, some concrete frequency of what that treatment will be. Who's going to be responsible? Who's a responsible interventionist for formulating and implementing this plan? And also, what is the expected date when the goal will be achieved? Now, this last one, while it's determined in advance, it may be changed. It may have to be extended because the person is not progressing. The person is not getting close to meeting those long-term, short-term. The person is not showing any measurement along the behavior outcome criteria. Or it may be shortened because now the person is progressing. They're progressing ahead of schedule. And also keep in mind with the formulation of the treatment plan, typically the client history, the case summary, and case formalization, and any DSM diagnosis may precede the treatment plan. So this kind of information you should have in advance of formulating the treatment plan.